Hey, all right. Well, my name is Andrea Sobrato, and I'm with CFPIC, and I have the pleasure of welcoming everyone to this training today, sponsored by CFPIC and CWDA. In fact, I'd like to recognize, she's not here, but I'd like to just recognize Diana Boyer, the Director of Policy for Children and Adults, and Baljeet Hundal, a former agency leader and someone who is uber familiar with CalAIM. CWDA has been really a wonderful sponsor and supporter of this work, and I hope you find value in today's training, as well as the opportunities for technical assistance that follow. Before I introduce our trainer, Gretchen Schroeder, I'd like to set the stage just a little bit. So if you could drop your name and county into the chat, that would be great. We are so pleased that you were interested in this training and thought it could support your county efforts. But this series of trainings, they're designed to not only provide a rich and somewhat in-depth overview of CalAIM, but we hope to provide a forum for deeper understanding and strategies and real insights to support your CalAIM implementation and strengthen your partnerships and collaboration with your managed care providers. You are in for a real treat today. Our wonderful trainer, Gretchen Schroeder, is a community health strategist and has extensive experience working with Medi-Cal and CalAIM implementation across a variety of contexts in California, from public health to CBOs to public social service agencies. She has both a history and experience working with Medi-Cal over the years, including payment models, negotiating contracts, and with understanding the ins and outs of claiming. She also has been around the implementation of enhanced care management all over the state, so can answer just about any question that you have. You're going to love hearing from Gretchen today, and we hope you come back for the 201 training. And we also hope you take her up on her offer for more direct support through her office hours later this month. You're going to hear more about that from her and from me once again at the end. We hope that you will experience today's training as really an invitation into a conversation. We don't want to necessarily be didactic. We know that Gretchen will be providing a lot of the content, but we hope you blow up chat. We have Baljeet, who is going to be fielding questions and then funneling them to Gretchen, and you will see that Gretchen will pause throughout the training to take questions and to answer and to really spend time around those areas that have a lot of energy around them through the chat and through what you're raising your hand and wanting to talk about. So we hope you feel like actually this is a little bit more of a facilitated conversation, and that this training is really just the first one. That CalAIM 201 training will take us deeper into the tenets behind enhanced care management and community supports, so that you are able to think about expanding capacity in your own communities. So we are heading into a conversation that is designed to really strengthen your ability for implementation and to really understand kind of the opportunities that are in front of your county teams. But we have a small enough group that we're not, I didn't turn this into a webinar, which really sort of block everybody out and all you can see is Gretchen. We're going to stay in meeting format. So feel free again to drop questions all along the way. We're going to route them to Gretchen. Like I said earlier, Baljeet is here to wonderfully complement Gretchen with insight from county services, from the county service side, and to bridge any gaps in terms of application. So she's going to be fielding those questions. We are going to meet until about 4 o'clock today, but we will have a stretch break sort of midway. And I am, as you know, recording the training. I will send a copy of the training out probably by the end of tomorrow to everybody who has participated in a 101 training. You will also get a copy of the PowerPoint slides that Gretchen will run in just a moment. I'll drop them into chat, and I can also send them out after if you prefer them over email. And again, we are so pleased that you are interested in this training and thought that it could be helpful to your county and your county team. And at this time, please join me in welcoming our trainer and facilitator, Gretchen Schroeder.
Great. Thank you, Andrea. Hi, everybody. How are you guys? Everyone staying awake so far in this warm afternoon? At least I'm in Davis, and it is warm in Davis. So anyways, welcome. I'm excited to be with you today. And as Andrea mentioned, I'd love to have this be a conversation rather than me talking for hours at you. So please raise your hand, come off mute. I want to make sure we answer all of your questions. I am going to share my screens. I do want to just point out that we do have, this is the last of our CalAIM 101 trainings that we're doing, which is kind of a 10,000-foot view on CalAIM, on the MOUs, lots of good stuff. And then we're going to be doing a 201 series, which is going to dive a little bit deeper into enhanced care management, community supports, and transitional care services. And that starts next week. And I'm super excited to do that with you guys. I love ECM and community supports, and would love to share all of that with you. So with that, I think we already mentioned we're recording this. I do just want to quickly go over our objectives today, which is to look at doing an overview of CalAIM and all the initiatives that fall under the CalAIM umbrella. We want to talk about how counties can build relationships with the health plan staff. I do know that a lot of you have already experienced and have some good relationships with your managed care plans, and some of you have not yet. So we'll start to talk about that. And I will invite those of you who are experts in this arena to share what you've done to develop some good relationships with our managed care plan partners. We'll go over a little bit more about Medi-Cal and managed care plans and how they're funded. I think that helps orient us to see how they're making decisions, maybe why they make some decisions they do. So we'll dig into that. And then last but not least, we will also go over all the MOUs, not all, the IHSS and CWS MOUs. We'll be doing that towards the end of the training. With that, we're going to start with a poll. So Andrea, I'll let you launch that. And we're looking, kind of just get a temperature check here from all of you of what brought you to this training. You know, were you here because the training relates to your job? You're just here to learn. Maybe you're new to county work and want to understand more about some of these areas, or maybe you were just told by your boss to show up today. So please let us know, and hopefully we can address everybody and where you are today. So it looks like most of you, we can release the poll. You're here because it relates to your job, which is great. So again, please ask your questions. Please jump in, raise your hand, come off mute. Really want to hear from you. So we do have quite a robust agenda today. We are going to talk about Medi-Cal a little bit, just an overview of Medi-Cal. I think it helps set the stage for why some of these changes that we're seeing are coming down through managed care. We do have some managed care financing pieces that we're going to talk about, just again to understand how managed care plans are thinking about it, and also help us understand one of those drivers of cost too, so that we can think about that in our own programs. We'll dig into building relationships with managed care plans. And then we'll dig into all the 11 initiatives of CalAIM, and we'll do kind of a high-level overview of most of them. Again, we're going to dig deeper into enhanced care management and community supports with our 201 trainings, which start next week. We'll take a quick break, and then we're going to spend the last part of the training going through the MOUs for IHSS and CWS, and then do a quick overview of behavioral health. And I know some of these things have been changing with the proposed budget that we've seen come through. So just want to make everyone aware of that there are some proposed cuts to some of the behavioral health programs we'll be discussing today. So let's jump into Medi-Cal. And I know some of you may be very familiar with Medi-Cal. You understand it inside and out, and that's wonderful. I also think there's probably a few of us here in the audience who Medi-Cal may be a little bit new to us, and we're trying to understand what it is and how we interact with it and how the populations we work with interact with it. So very simply, Medi-Cal is California's Medicaid program. Just like every other program in California, we have to rename it to something with Cal in it. This is really a public health insurance program, which is providing needed healthcare services for qualifying individuals. Well, who are those qualifying individuals? They are typically low-income individuals, which includes families with children, seniors, parents with disabilities, foster care, pregnant women, and low-income folks with certain diseases that may qualify them for Medi-Cal specifically. So we're really talking about the low-income, vulnerable populations that you may be working with. Again, very simply, Medi-Cal is financed about 50-50 between the federal government and the state of California. Some programs, some populations are reimbursed at a higher rate through the feds than others, but just very simply, it's about a 50-50 share of cost in California. Other states, the federal government assumes more of the cost, but in California, it's about 50-50. Enrollment, so the numbers I have here from January, they're a little old, but things are not changing significantly. We have about 14.9 million people in Medi-Cal from January. We hover around that 15 million mark month to month. And what's really important here for our purposes today is looking at how many folks are enrolled in managed care. So in January, about 95% of our Medi-Cal population were enrolled in managed care. And again, that percentage hovers 90 to 95%. So when the state started to think about how we want to drive change and transformation through Medi-Cal, it became quite obvious that all of those changes need to really go through managed care in order to impact the most people. So that's why you see CalAIM really being pushed through the managed care plans. Any questions on this? Okay. In Medi-Cal, we have two primary models of delivery. There's several others, but the primary ones that we'll talk about today are fee-for-service. And this is where the state pays providers directly for each service, and there's no defined network of providers. The other delivery model is through the managed care program, through the managed care plans, and that's where the state contracts with Medi-Cal managed care plans. The state pays the Medi-Cal managed care plans what's called a capitated rate, or a per member per month payment for all of the covered services under Medi-Cal. So if Andrea is going to be insured in Medi-Cal managed care, the state may pay her health plan $100 a month, let's just say, for all of her services. And it's up to the managed care plan to really prioritize how they spend those $100 for Andrea. And that's where you'll sort of see the variations in plans and some of the programs they promote. The managed care plans do establish a network of providers and pay them directly. And of course, from the managed care plans to the providers, payment models vary significantly, and they vary between counties and regions. So you may see differences just county to county in how folks are paid and the rates they're actually paid. So now we're going to jump into a little poll. So I'm just curious how you guys are kind of interacting with Medi-Cal and understanding for the populations you're working with. How do you know if they're actually in Medi-Cal? And how do you know if they are in Medi-Cal if they're in managed care? So I'm curious for you and your staff, how do you guys look up someone's Medi-Cal status? Do you use the MEDS program, AVES, CalSAWS? You're not sure, or you have other ways? You have a best friend who works in the eligibility office and you call them. Let us know how you guys are looking that up. And it's okay if you don't know, not all of you are going to interact with folks individually, but I'm just curious in your county how that's done. All right, so it looks like most of you are using MEDS, and then we have CalSAWS coming in next. And then if you did choose the other one, I would love to have you throw in the chat. What are some of the ways you are looking up someone's Medi-Cal status? It's just interesting for all of us. One of the big things we deal with, not only with county staff, it's some of your provider agencies in the community, is how do they know if someone's enrolled in Medi-Cal? So we're trying to understand the different mechanisms folks are using. So Jessica, you are using CMIPS, which is interacting with MEDS. Okay, great. CalSAWS. Okay. Have to ask eligibility. Yes, all kinds of different ways. This is really helpful. Thank you, guys. So as we look at Medi-Cal managed care plans, we do know that there's kind of two different categories of plans. And of course, they all vary just in and of themselves. We have the commercial health plans, and there's 5 of those in California right now. We saw a reduction as of January 1st. And then we have about 17, which are local health plans across California. And the local health plans may serve only one county. They may serve a set of contiguous counties in the state, but they serve about 70% of our Medi-Cal managed care enrollees, and they're in about 51 counties right now. Now, you'll hear a lot of folks disparage the commercial plans. All they care about is their bottom line. They're not in it to serve the people. And I think, there's probably some truth in that, but I've also found that there are some pros to those Medi-Cal managed care plans that are commercial. Sometimes they have economies of scale, which allow them to really do more programs and offer more services. Some of our smaller plans can, just due to staffing. We are also seeing some of the commercial plans really specialize in certain things like housing, and they've really invested in trying to bring housing providers, for example, into Medi-Cal and really working on that. So you do see pros and cons to that. I will say there's pros and cons to our local health plans. Some of our local health plans, since they are so small, they sometimes are not as fast to roll out the new programs the state has been pushing through them. So it's been some challenging counties around the state to have some things be quite delayed. But they do often make investments back in their communities. Most of their staff usually live in the counties they're working in. So again, the pros and cons for both. But I do think fundamentally, both types of plans do care about their bottom lines. They have to stay in business, and so they are still focusing on making decisions that are going to lead to financial sustainability for them. Just because we want to make everything complicated in California, we have about 5 different Medi-Cal managed care models across the state. And some of you may be familiar with this for your counties. Some of you may be learning this for the first time. I'm going to start in the top left-hand corner with what's called our COES model, which is our County Organized Health System. And that's where the state contracts with a managed care plan that is run by a county or city government entity. And it's the only managed care plan in the county. So a few of you may just have that one managed care plan, good and bad. You have one that you're having to work with. We also, moving to the right, we have our regional model, which is where the state contracts with 2 commercial managed care plans that are serving 2 or more contiguous rural counties. If we move down, we have single plan model, which is where the state contracts with a managed care plan that operates under the authorization and sponsorship of a county or local authority. It's a little bit different than our COES system. I'm going to save our bottom one for last. We'll start to go the 2-plan model next, and that's where the state contracts with 2 commercial plans that are serving very clearly defined geographical areas. And then the bottom one, our geographic managed care plan, we have 2 lucky counties, Sacramento and San Diego, that have multiple commercial plans. And so Sacramento has 4, and I believe San Diego, you're still at 5. So they have a lot of different coordination that they're doing between those managed care plans. Any questions on this model? And if you're not sure what model your county has, here is a pretty basic map of where things are. I am going to point out that you're going to see up here in the top northern part of the state, those are mostly COES models. And actually, that's where a lot of the partnership spread has happened, especially this after January 1st of this year. They've really moved into a lot of those northern counties. Our green, our geographic managed care model, you'll see Sacramento and San Diego down here. And so you can see where you fall. You also may be aware that Kaiser started a direct contract with the state, and they moved into many, many counties as a direct contract with the state in January. So they are coming out and building their presence in a lot of these counties. They weren't as established before, so you're starting to see Kaiser come into more and offering different services there. Any questions on that? All right, so let's talk about what does Medi-Cal offer? Why is it so important? So Medi-Cal has benefits. This is going to be a key word as we talk about some of the future CalAIM initiatives. And the benefits are really a comprehensive set of health benefits, which must be provided across the state, no matter which managed care plan you are in. And we have a list of all of pretty standard services that Medi-Cal does cover. What I do want to highlight is those bottom ones under the other category in the turquoise or the light blue. And this is where some of the new benefits may come under Medi-Cal. And so we're going to see, for example, in that new other benefit category, we have enhanced care management. We have the community health worker benefit. We have some transportation services, and of course, some long-term services and supports. And so as the state adds more programs, if they're not standardized under the Medicaid platform of care, or if they're under a waiver, which the state gets special approval from the federal government to offer these new services, they will often fall under the other category. In Medi-Cal, you may often hear the term services that are carved out. And so what does that mean? Why is that important? So what that's looking at is that the services that are carved out of Medi-Cal are actually just not going to be offered through the Medi-Cal managed care plans. They're going to be offered by another delivery system. So if we look at specialty mental health services, that could be under a county mental health plan. You're going to see some of the substance use disorder services as well, dental services, et cetera, et cetera. And so these are carved out. So your typical Medi-Cal managed care plan is not offering that. Another delivery system, often counties are the ones who provide those services. I do want to highlight the specialty mental health versus the non-specialty mental health, because we do have patients that get services through both delivery systems. So your specialty mental health, that county mental health plan, and then you have the non-specialty health, which is underneath the Medi-Cal managed care plans. So I typically think of the non-specialty mental health services being part of a medical condition. And so that's kind of how I think about it in my brain when I categorize what's specialty and what's non-specialty here. Some of the services that the specialty mental health plans offer include rehabilitative, some in-person, there's targeted case management, which I know is shifting a little bit with enhanced care management coming in, but you can see all of these different services are falling under the specialty mental health services. Any questions on carve out or some of the benefits? All right, so far so good. Let's jump into share of cost. So a few of you may be familiar with this Medi-Cal share of cost term. And what this is saying is that sometimes families or individuals don't fully qualify for Medi-Cal, and they have to spend a certain amount of money each month before their Medi-Cal benefits kick in. And some of the populations that we see impacted by this are going to be our IHSS individuals, some of our families, some of our adult and aging clients. And what's important about Medi-Cal share of costs is these individuals do not qualify for managed care. So a lot of the new benefits that are coming down through managed care, they will not be able to access. So I think as you look at working with your populations and what benefits there are to managed care and keeping them in fee for service, some of these factors may be important to consider. You don't always have an option to change them, but sometimes you do, and it's important to understand that managed care is where these new benefits and programs are available. All right, time for their poll to make sure you all haven't fallen into your after lunch coma. So this one we're going to see, I know some of you work with populations where you do have an option to have them either be in fee for service or managed care Medi-Cal. And so I'm curious, for those of you who typically have been using fee for service for your populations, what are the benefits for individuals you're working with? Have you found that fee for service enables easier access to providers? Is it better for care coordination? It's how we've always done it. I've heard a lot of people say, I don't understand managed care. I don't want to learn it, so we're not going to use it. And then there may be other reasons that we have yet to uncover about why folks are still enrolling populations into fee for service, or not discouraging folks from enrolling in fee for service. All right. So again, this is what we saw in our previous trainings too. A lot of folks just say we don't understand managed care, which is a hard thing. So understanding what it brings, what are the pros and cons of managed care versus limitations. And I know especially for folks who work with foster youth, sometimes it's hard because if they're changing assignments and going to different counties, sometimes managed care can make that a lot harder, and fee for service could be easier. So depends on who you're working with. All right, I see we do have a question in the chat from Bruna. Help me understand why a mental health managed care plan would insist in having words like medical necessity when accessing specialty mental health services for foster youth. That is a great question. It's really interesting to me that you're asking this. I think the state has been trying, I'm not saying it's been successful, but the state has been trying to really have a no wrong door policy for foster youth, especially around accessing mental health services. And so some of the things that we're seeing is they're trying to really break those barriers down. It may not always be happening. I'm going to see Baljeet or anybody else have any other ideas for Bruno.
I think what we're learning from the managed care plans is that there is a clear divide in who provides what level of mental health services. And so typically managed care plans are authorized to work with folks who are considered mild and moderate. And typically the state wants your local behavioral health, your local mental health plan working with folks who are seen as serious, more serious than the mild and moderate. And so this may be a way to kind of define that more for the managed care plans.
And Tamara, thank you for raising this too. We hear this a lot as well, that those words, medical necessity, is really tied to making it covered for billing. Bruna, do you want to come off mute here? Great, come on up.
Okay, so if you know, putting those words so that there's definite lines of who's responsible for what kind, for what type of service. Are they still supposed to work together though? Like when,
Yes.
so how do we foster what are the correct language to put in some sort of document that says we'll do that, or that they will do that, or help us navigate through that? I think that's what the Department of Social Services would need help with, through the managed care plans, to navigate that with managed care plans and our health managed care versus health managed. That's,
I think, yes, this is the ultimate question. How do we coordinate care? I think there's some language in the MOUs, especially around foster youth, that can help build those bridges and have those, you know, either whether it's a workflow document or some of the policies and procedures can definitely support that. One of the things that I think there's some counties on here who probably have great experience with this, but I think trying to build those relationships with your Medi-Cal managed care plan so you can have these conversations, so you are working together and understand what the expectations are from both sides, is going to be really important. And Baljeet or anybody else, if you also want to jump in here and share your experiences, please do.
Yeah, so, you know, just because the managed care plan isn't necessarily responsible for these specialty mental health services, they are not off the hook though. They have to, once it's identified that one of their members needs these services, they have to coordinate with the entity that is ultimately responsible for them, right? So it's like they have to help and refer and assist and do that care coordination for that member. And it is in the MOU for the child welfare population. It's something that we really want county staff to know what the managed care plans are responsible for, what their array of services are, so that when they don't speak up and share with you, this is what we have to offer, you can ask for it yourself, because we are seeing some of that happening, where a county may refer a member for a particular service. The managed care plan may say that the member doesn't qualify. Then they're supposed to provide additional other services that they may qualify for. And so part of a lot of the training is about helping you understand what the managed care plan is actually responsible for, so that we can advocate for our populations that we serve.
Great, thank you, Baljeet. Anyone else want to offer any words of wisdom? All right, great. So we're going to wrap up this very brief section on Medi-Cal overview here. I do want to just make sure folks know how to understand what managed care model that their county is using, which plans are in that managed care model, so you can start to build those relationships. I also really encourage you for yourselves or for your staff to make sure folks are knowing how to look up someone's Medi-Cal status. Again, as we start to see more and more benefits rolled out through managed care, it's going to be really important for you all to know which of your individuals you're working with are already enrolled in managed care, and if they're not, is it appropriate for them to think about enrolling in managed care? Nicole is asking, Baljeet, I'm going to turn this question over to you. Can you explain why IHSS recipients are not eligible since they are on Medi-Cal?
So can I just ask, Nicole, eligible for what?
It was mentioned earlier that IHSS individuals are not they don't qualify for the managed care.
Oh, okay, they do. And I think what Gretchen was talking about is that as we've really delved into CalAIM and understanding the responsibility of the managed care plans, we then kind of stepped into this share of cost issue that some of our members are on a share of cost, which means that they cannot get into a managed care plan. Now, the alternative might be PACE if it's available, and I'm waiting. I just emailed a policy analyst at CalPACE to find out if they actually take share of cost Medi-Cal members on the PACE program. And if that program is in your county, it's actually an alternative to what CalAIM is being provided through the managed care plans. And it's kind of like a one-stop shop where you get all your needs and services. It's a brick and mortar. It's a place to actually go, and a multidisciplinary team actually works with you. So that is another potential alternative for folks that can't get on to managed care plans who are 55 and above. So we are looking into that. Hopefully I answered your question.
Yes, thank you very much.
And thank you for raising that, Nicole. I do think it's important that when we listed that share of cost slide, these are populations that may be impacted by share of cost, but not all of those populations would necessarily not be eligible for managed care. And again, why it's so important, this managed care enrollment, is because a lot of the CalAIM benefits, if not all of them, are being rolled out through the managed care plans. And so if you're not in managed care, you will not be able to access things like enhanced care management, community supports, some of the justice involved initiatives that the state is rolling out. So that's kind of why we're harping on this, knowing who's in managed care, who's in fee for service, who actually may not even be enrolled in Medi-Cal and may benefit from looking into that more. All right, and Mike, I see you're asking, our skilled nursing clients were all converted over to managed care plans, but they all also have share of cost. Okay, how does that work? And so Baljeet, you answered that in the chat. That's our understanding from the state that anyone with a share of cost is on fee for service Medi-Cal, but we can definitely look into this more. Yeah, that was our understanding from all the literature that we've read and the state has put out. So thank you for raising that, Mike. All right, so we're going to dig into one of my favorite topics, which is Medi-Cal financing. I find all of this so fascinating, and I want to share a little bit with you just to help us understand, as we engage with the managed care plans, what are some of the drivers they're experiencing to do some of these new changes and transformations. So very simply, again, breaking this down into very simple terms, the Medi-Cal budget is ginormous. I mean, it is huge. And what I think is really important to think about as we see all these transformations roll out is what is driving the costs for Medi-Cal. How do we see the budget go up or go down? And sometimes it's counterintuitive. And so the three big drivers for Medi-Cal spending are around eligibility expansions or contractions. And so we've recently seen the state add more populations who are eligible for Medi-Cal, so that will increase the budget. We also know that as the budget, is terrible at the state, that's going to trickle down to more individuals and families. And we're going to start to see more people become eligible for Medi-Cal. So again, the Medi-Cal budget will then grow again. We also know that when you add new programs or new benefits to Medi-Cal, that will impact spending on Medi-Cal. And then, of course, one of the things that CalAIM is really trying to tackle here is how Medi-Cal enrollees or Medi-Cal members are utilizing the healthcare services. So are we seeing a huge increase in folks going to the emergency room for care that could be better addressed in urgent care at your primary care doctor's office? So trying to look at what are those utilization patterns, how do we get folks the most appropriate level of care that may be cheaper and save us all money in Medi-Cal. So this is kind of what we're starting to see happen with CalAIM. So again, as we talked about earlier, Medi-Cal managed care plans, they are paid a capitated rate by the state for every member that's enrolled with them. And that is primarily a per member per month payment. So for Andrea, we're going to pay $100 to a health plan to cover Andrea and all of those covered benefits under Medi-Cal. These rates are developed on a calendar year. And given that the feds share in California essentially 50% of the cost for those folks, we have to get that approved by the federal government every single year. If you are familiar with Medi-Cal and looking up, Medi-Cal for individuals you're working with, we know that there are different categories of aid where folks fall under. So that can be really informative as you start to work with more and more individuals to understand which categories they fall under. Now, the state pays the managed care plans a capitated rate. We're also going to see the managed care plans start to pay their providers in many different ways. But the three primary ones that we're seeing across the state are going to be per member per month as well. So that may say that you are going to be paid $50 if you're working with Baljeet, but you must touch Baljeet 3 times during the month. So you may have to engage with her face-to-face for 3 times to get that payment. Sometimes you can text her. It all depends on what the contract says. But for some of our care coordination activities, we're getting a per member per month payment. They also will pay providers a fee for service payments. That could be per service, per 15-minute increment, per diem. Really depends on what the service is that is being paid for. And then one which is familiar to counties, I know, but not always familiar for other programs, is this cost-based reimbursement. And so we're seeing that used pretty sparingly for managed care plans to pay providers, but we are seeing some of the new services fall under this cost-based reimbursement system. The thing that we think about a lot is as we move into these new programs and different providers start to enter into getting a per member per month payment or a fee for service payment, what does that do to budgets? So if the county wants to become, let's just say, an ECM provider, you may get paid a per member per month. How does a county department shift their budgeting to reflect that PMPM payment versus perhaps a cost-based reimbursement payment they had been getting through other programs? So that's one of the challenges we see across the state with our community-based providers, with county agencies, that some of these payment models can be very difficult to adapt to. They may require more intense data collection for invoicing and billing than we've seen before. So it's just causing a lot of, I say, upheaval, I think, for a lot of organizations to adjust to some of these Medi-Cal payments. So that was my very brief section on Medi-Cal financing, not too crazy. But just looking at, again, what payment models do you guys get? Have you worked with any programs that may have a PMPM or a fee for service payment? What would that do to your budget, your programs, your staffing model to have to shift to one of these payment models? So just food for thought here. Any questions on what we just covered on Medi-Cal financing? Okay. Now let's talk about the managed care plans. And this section is really about how to build relationships with managed care plans. I know several counties on here have done a great job. So again, I invite you all to share your lessons learned, your successes here. But I will say, I think for a lot of us, we may have a negative connotation with the managed care plans. We really don't understand how to engage with them in a meaningful way. We don't think they understand the programs that we run or the populations that we work with, which probably is true for most of you, right? And so I think it's really important to start to think about how do we start to build these partnerships? What can we do to help the managed care plans understand more about the programs we run, the populations we serve? And again, it's not your job to be their teacher, but I think there is a benefit for all of us to think about how do we increase managed care plan staff knowledge on the programs and people that we are engaged with. So I think I will also say this, and I'm not trying to be pro MCP, but I am going to say this too. I think there's probably knowledge gaps, and I will say I am one of them. I used to work on whole person care in Sacramento, and there were a lot of knowledge gaps we had about how managed care plans work and operate. What are their internal drivers? How do they think about these things? And so I had to do a lot of work on my own to really understand how they were approaching problems that we understood it was important for our populations. We had to learn to engage with the managed care plans in a way that we both were understanding each other. So I encourage you all, just get to know them, invite them out for coffee if they're local, and try to educate them when it's appropriate on what you do, how your county operates. And I will say a lot of managed care plans, I think it's changing, but a lot of them still think I know one California county, I know all California counties. And so they may not understand the differences in terms of operations between counties that may have a super agency and counties that don't. So again, just be aware there's probably knowledge gaps. I think those can be addressed and quickly rectified, but they do exist out there. Some of the other issues we've seen with managed care plan staff is that it's hard to understand all the right people that you need to engage with, because you're often maybe assigned a person who's your regional point of contact with the managed care plan. And they're great, but they don't really have much say in terms of contracting or rates negotiation or any of those things. So you may have to talk to somebody else in the managed care plan about contracts. So just understanding again how that managed care plan operates, who has the information that you may need on a particular issue. So it can be complicated, especially those bigger commercial plans can be challenging. So I would just, again, anybody here who's had a lot of good relationship building experience with managed care plans, I have listed my tips and tricks here, but I welcome everybody. And I know Sacramento and San Diego, you guys have done a lot of work since you have multiple commercial plans to really engage them. But my biggest thing is start talking to your managed care plan reps, invite them out for coffee, invite them to your meetings. I found a lot of managed care plans are really starting to come to more and more meetings. They want to learn, they want to be engaged, they want to make things better. So invite them, get to know them. They would welcome that. I said most, probably not all, but most folks I've worked with really welcome those relationships. I know it's hard if you're in the midst of contracting, but if you have questions, ask your managed care plan person. We had a lot of challenges early on in whole person care and health homes and enhanced care management and community supports. Folks did not know how to bill Medi-Cal in a certain way. And so it took a lot of organizations asking questions over and over for the managed care plans to understand that it is a real challenge for non-traditional Medi-Cal providers to figure out how to bill Medi-Cal. Once the managed care plans kind of understood that by folks asking questions, they've responded in a very positive way. The other thing, and I had this experience happen yesterday, I was in a meeting with a bunch of managed care plans and some county partners and CBOs. Share your success stories. We are all working so hard, and I think sometimes we get compassion fatigue. We just, what's the point? Are we making a difference? So sharing your stories, your success stories with your colleagues, with your managed care plan partners is all going to benefit everybody in the end. So I encourage everyone to do that. Any other counties want to jump in with their tips or tricks for engaging with your managed care plan partners?
Hi, I just wanted to add for San Diego for our child welfare population. It's been newer for us to engage with the managed care plans, and so we've really relied on the folks in our agency that have those relationships. So our Medi-Cal services team, our eligibility staff, and just sort of building on the relationships we have with them. So sort of identifying who those experts are that have those relationships, and then being part of that with them has been helpful for us in San Diego.
That's great advice too. Some of your other county departments may already have these relationships, so trying to have that warm handoff is great. Anybody else? All right, not to end on a down note, but a lot of us would like to see rate negotiations happen with our managed care plan for certain services or programs that we're working on. And unfortunately, and I'm hoping this is going to start to change, but at least right now, we are not seeing the managed care plans be open to rate negotiations for a lot of the new CalAIM initiatives that are rolling out yet. I think that's going to change in the near future, but I would say I encourage you all to start negotiations with your managed care plan and make sure you have your cost data to support any kind of requests you have around increasing rates. But at this point, I'm not hopeful that we're all going to get the rates that we want through some of these programs. But again, keep trying. I think it's important for the plans to understand what does it cost you in San Diego to do a certain program that may be different than what Bruno's paying in Fresno. So I think just having them understand the regional differences. And sometimes, surprisingly, we're seeing the managed care plans go, what? it's more expensive in rural communities than in urban communities to do some services. So they need to understand all of that and be aware of the different needs of the providers they're working with. So we're just moving through our agenda, which is great. Now we're going to come to our CalAIM overview, and this is a doozy. So bear with me as we walk through most of the 11 CalAIM initiatives. I do want to point out that the state has tried once again to rebrand CalAIM into being called Medi-Cal Transformation. I am going to use CalAIM here. That's what it's always been. I think we're going to fall back to that again, but they are now trying to say CalAIM is Medi-Cal Transformation. It all means the same thing. We're trying to change Medi-Cal. We're trying to roll out new benefits. We're trying to make improvements in the system. And I think throughout all of the initiatives, you're going to see these themes come through. We are trying to build a more coordinated, person-centered, and equitable health system in California under Medi-Cal. We're trying to break down silos between our clinical services and our more social determinants of health services like housing, like food, like asthma remediation. We're trying to break those barriers down so we're all working together to meet the needs of an individual. We're trying to really create that health equity. So there's a lot of pushes and all of the CalAIM pieces around health equity, around justice. And so keep that in mind as you go through all the initiatives. We're all trying to drive towards that. And then again, trying to work together. So build more collaboration, more cooperation between managed care plans, between counties, between community-based providers to try to serve these individuals to the best of our ability and meet their individual needs. So along with the CalAIM initiative, the state has also rolled out these bold goals, they're calling them. And I think as I'm starting to see more and more managed care plans try to roll these bold goals and these aims into their programs under CalAIM, and some are actually paying some incentive dollars to providers to try to work on these bold goals here today. But here's what we're looking at, and here's what the state's driving towards. They want to close the racial and ethnic disparities in well child visits and immunizations. They want to close maternity care disparity for Black and Native American persons. They want to improve maternal and adolescent depression screening. So again, probably a lot of you are doing this work already. So how do we start to wrap this up and let the managed care plans know you're working on this? How do we improve follow-up for mental health and substance use disorder? And then, of course, we always want to do this, ensure that all managed care plans are exceeding the 50th percentile for all children's preventative care measures. So immunization, just well child visits, all those things. We're trying to really drive equity through these bold goals. So one of the things that we think about with CalAIM and Medi-Cal transformation is the continuum of care management services. And so you're going to see this, it's not quite a triangle, but that's the intent here. And we're trying to really target folks with the highest needs, who are the most vulnerable and the most expensive, through enhanced care management, one of the pieces of CalAIM. So we're trying to really drive that care coordination, getting folks to use the most appropriate level of care, again, meet their health needs and save dollars, reduce costs for Medi-Cal. We also have these two bottom purple pieces of our triangle, which are things that already exist. And again, I think a lot of these have not been well known. So I want to make sure we're all aware that ECM is the great care coordination piece. There's other step down care coordination programs that do exist and people can access. One of them is the complex care management. And again, this is under managed care, but it's really trying to address folks that have a medium or rising need, very ill, may have chronic conditions, and they may need assistance in coordinating their care. So looking at that. So oftentimes we see individuals who go into enhanced care management, and as they stabilize, they step down to our complex care management. And that is often just run by the managed care plans. And then we have the bottom of the triangle, which is basic population health management. We're really trying to serve everybody with our wellness and preventative programs, and you will see those available to all managed care plan members, regardless of acuity or regardless of chronic conditions. This should be available to everybody. So now our fun slide, our puzzle pieces. We're trying to fit all these things together in California under CalAIM. We're trying to coordinate care. We're trying to reduce barriers and silos, and we're trying to work together in this more coordinated system. So again, as I mentioned, there's 11 initiatives under CalAIM. I'm not going to cover all of them. We're going to cover some of the bigger ones today at a high level. And then, as we mentioned earlier, we're going to dive deeply into ECM and community supports and transitional care in our 201 training series, which starts next week. But here are the puzzle pieces, and we're going to start with population health management, as this is the cornerstone of CalAIM. This is one of the things the state is really pushing, and you're going to start seeing and hearing more and more about this because they're really trying to make some changes in the next year. So PHM launched in January of 2023, and it's a statewide approach. And again, think about the CalAIM piece. We want to serve the individual. We're also trying to standardize access and standardize assessments and standardize approaches to care. And so they're trying to roll out, how do we stratify folks? What risk assessments are we using to make sure that we're all talking about risk and acuity the same way? We're trying to address individual needs. And so we're really trying to drive all of that health equity through population health management. There's two components to our population health management initiative. One is the program, and that is really trying to have a set of services that are comprehensive, that are standardized across the state. So if you live in Sacramento or you live in Madera counties, you're going to have access to the same assessments, the same services, no matter where you are. Again, trying to drive health equity. And this is trying to really ensure that we're not looking at needs just at a population level, but also understanding the needs of the individual. And the second part of population health management is the service. And this is what's still being rolled out. And it's more of a technology service. We're trying to collect data and we're trying to share data so that we don't have to ask the same questions, do all the same assessments over and over again for an individual. We're also trying to make sure that we can understand health trends across the state. So are we having higher utilization in Monterey County than we are in Mendocino? What's happening there? What are the trends that are driving these different utilization patterns? So we're just trying to collect more data, share more data, and standardize the data that we do have so we can start to better understand what's happening across the state using the same lens. So this is being rolled out now. I'm just hearing this more and more in meetings. We're trying to do this rolling out. Again, this is coming primarily down to the managed care plans, and they are working with some providers to start to build this data system and integrate systems data already. So you'll start to hear about this more and more if you haven't already. Again, high level overview. Any questions on population health management? Yes, Bruna.
So here in Fresno, we have, we are hearing that, but it really does sound like the start is for those that actually truly provide the health and or mental health service. So Department of Social Services kind of out for that portion of it. I'm trying to figure out when we jump in and to what extent we're not HIPAA because we're not providers, but we do hold information on health services for our foster youth. So just trying to figure those steps out. And right now, I'm not really paying attention because everything on me says if you're a clinic or you're a health provider, you have to sign this agreement to jump in to this population health. So is that correct?
I think you're expressing what a lot of people are feeling across the state of like, we know this is happening. It sounds like it's primarily happening in just the clinic realm or the clinical services realm. The intent is also going to collect data on social drivers of health too. So who's out there who's having unsheltered homelessness? So can we get HMIS data into this? They're trying to really bring this together. I think the rollout has been a lot slower. They've had to push back timelines over the past year and a bit with the service especially. So you will see this. Parallel or adjacent to the population health management is some of the data sharing that's needed for care coordination. So if you look at the MOUs, which we'll talk about a little bit later, there's a whole section around data sharing. And I think This will hopefully feed into the population health management service, but there may be more immediate needs for the care coordination. Does that make any sense? I know it's not an answer, but maybe it makes you feel like you're not the only person trying to figure this out.
Correct. Thank you.
Great. Anybody else have questions? All right, so we're going to move on to the behavioral health initiative. Again, I'm doing very high level overviews, and I apologize. These are all so rich and have so many components, but I just want to give you a taste of what it is. And again, most of these are being driven through the Medi-Cal managed care plans. So behavioral health, again, trying to build in that coordinated person-centered care model, breaking down silos between providers, and trying to streamline and standardize how we're accessing care and the care that we're getting. And of course, this one is really trying to push out payment reform. So we're actually paying folks for the outcomes that the state wants to see. We're trying to develop policies that will support this. So this is a huge initiative with a lot of different pieces trying to be driven through it. Most of the pieces of the behavioral health initiative have gone live in the past year or two. So you'll see that here. Again, they've gone live, and how they're being rolled out with each managed care plan and each county can vary significantly, but they're all live with the exception of the last piece, which is the administrative integration. Next, we're going to just do a high-level overview of enhanced care management. We've talked about this a little bit. This is really one of the new shining stars of CalAIM. We're trying to really improve care coordination for our highest need, highest utilizers, most expensive patients across the state. So we're trying to look at how do we really engage them in accessing the most appropriate level of care. And as you all probably know, sometimes initially that means folks are going to utilize more healthcare services as they've just come into the system, may need some immediate needs addressed. But as we learned in previous programs like whole person care and health homes, the usage utilization decreased over time as once folks got stabilized and learned how to access the appropriate level of care. So we're trying to deal with this through a lead case care manager and enhanced care management who's trying to coordinate health and health related services. So this could be helping them make doctor's appointments. It can also mean helping them get their identification card, apply for SSI. It can be a lot of different things trying to help that individual become more stable. And again, some of the counties here today, you may already be ECM providers. Some of you may be thinking about it, and some of you are saying, what the heck is this ECM thing? Tell me more. So again, very briefly, there's 7 core services for enhanced care management. They're listed here. The biggest piece is going to be having that comprehensive assessment and care management plan and doing the coordination for that plan. Those are the big components of ECM. Who is eligible for ECM? Again, a new benefit through managed care. The state rolled this out in phases, thankfully, and they organized it by populations of focus. And again, this came out of whole person care and the health homes program. So if you're a whole person care county, this may be more familiar to you. But they rolled out for folks who were experiencing homelessness, looking at people who are those high utilizers of our healthcare system, looking at folks who have serious mental illness or SUD needs, and they've kind of rolled that out. As of January, all populations of focus have gone live, and they are all eligible for ECM. I am going to point out that utilization and enrollment in ECM is very low. And the state was thinking 3 to 5% of our Medi-Cal population would get ECM. We're seeing about 1% enrolled and utilizing ECM right now. So a lot of room for growth. And I think as I look at the county's roles and things, we do have a lot of populations of focus that have rolled out in the past maybe 6 or 9 months. Our children and youth population of focus, our other adult populations that you all may be working with. And so just being aware this program is out there, they have to be enrolled in managed care to access this benefit. And again, thinking through what the benefits may be for the populations you're working with. Any questions on our high-level ECM overview? All right. We'll jump into community supports. This is often considered kind of the parallel program for ECM. This is not a Medi-Cal benefit. This is an optional service that managed care plans can offer. and that members can opt into. The managed care plans are not being paid any additional dollars for community support. These are supposed to be cost-saving programs. And the state gave the plans options of which community support services they wanted to roll out across their regions and which ones they choose not to. And they may choose not to because there aren't providers in that region, or they may choose not to because it's not really a cost saving measure in their mind. So lots of different components, but community supports is not a Medi-Cal benefit. So this is really trying to address those social drivers of health. So looking at housing, at food, community-based services. There are currently 14 pre-approved community support services in California right now. Managed care plans can choose which ones they provide, and they can choose to add more community support services every 6 months, excuse me. Most plans in most counties are offering close to the 14. Again, some have experienced some provider shortages. Others have been a little bit slower to roll this out, but we're seeing a lot of counties having most of these services available. One of the things I'm just going to point out, because we do have another community support that's going to be coming down in probably the next 6 months, but housing deposits, which is up to $5,000 for the most part. Some plans have changed the dollar amount, but essentially the plans are giving housing providers $5,000 a month to help get somebody housed. And that there's going to be a whole list of approved services, approved things they can purchase, like mattresses, like bed frames, those kinds of things. But essentially we're trying to get somebody housed. It's a once in a lifetime benefit. And I will say that there's a lot of organizations that struggle to do this. And so I'm going to just encourage counties to think about this. The new community support service that's coming through is transitional rent, which is where the managed care plans can choose to provide 6 months of rent for an individual to help them stabilize. That just got approved recently. It's coming down through the managed care plans. We have a lot of questions. We don't know a lot about it, but I think, again, as we think about some of these large items that we want to see in our communities, we need to figure out who the providers are that can do this. So again, just pinning for counties to think about this. Who do you work with? Who are you engaged in? Are you someone who might be able to do this kind of a service? All things to think about. My little push here. Now you're thinking to yourselves, these are all great programs, love it. Who can afford it? How do we do this? The state is trying, or I should say pretty much has tried to do some startup funding for organizations, including counties, including community-based organizations, to jump into doing some of these CalAIM initiatives. And there's 2 primary funding sources that have been used for enhanced care management and community supports. And some are going to be drying up in the next 6 months or so. So I'm really encouraging folks, if you're thinking about becoming an ECM or community supports provider, or you know of organizations who want to, there is some startup money out there, but I do expect it to be going away in the next 6 months for the most part. So there's 2 primary funding opportunities here. One is the PATH funding, which stands for Providing Access and Transforming Health. And this is really trying to build up the capacity and the infrastructure of providers. And we have 4 different pieces the state is paying for right now to help do those capacity building, infrastructure building activities. One is what we call PATH Cited. And these are grants straight from the state to providers who want to be or already are enhanced care management or community supports providers, to help them hire staff, help them buy technology systems, help them rent office space, help them, et cetera, et cetera. There's all kinds of things you can use PATH Cited for. There have been 3 rounds of funding of PATH Cited, and we expect there will only be 1 more, which will be, the application will open up, we think, in October. So again, if you are thinking about becoming a provider, I would just be aware that this funding opportunity is out there, and there's, at this point, only 1 round of funding left, which will open in the fall. The next piece of PATH is what's called the Collaborative Planning and Implementation Initiative, CPI. These are collaboratives across the state. There's usually one in every county or one in certain regions. The state is paying facilitators to run these, and they're trying to bring all of the ECM and community supports providers as well as partners into the same space to break down those silos, to increase referrals, to coordinate care. So if you are not part of this, but are thinking it might benefit you to join in, find out who are the providers in your county who are doing ECM or community supports, the CPI program is a great thing to join, even just got the mailing list for all of the PowerPoint. So I encourage you all to look at that. And I am involved in a few CPIs, and we're always anxious to have county staff come in, because oftentimes those county staff are a missing piece for how do we create this more coordinated care system for these individuals that folks are working with. So I do encourage counties to think about that. PATH has also developed a funding initiative just for the justice involved capacity building. So we'll talk about this in a few minutes, but there's a whole big justice involved initiative being rolled out, trying to provide Medi-Cal services pre-release and to coordinate care after release. And so looking at how do we start to invest in the infrastructure needed to do that. So there were a lot of grant rounds. I think there's one or two still left for justice involved county departments, probation, sheriff. I think they also have some community-based providers who are eligible for these grants. And then last but not least, we do have what's called the Technical Assistance Marketplace. And this is a place for folks who either are in the process of becoming a contracted ECM or community supports provider, or who already are a provider, to get free technical assistance from vetted vendors. They're on the website, you can look them up, and the state will pay for it. So again, if you are thinking about doing this, know providers you work with who may benefit from some TA. The TA marketplace is up and running, and it is free TA the state will pay for. So I encourage all of you to look at that. And I know Andrea is going to remind me to make sure that CFPIC is becoming a vendor on the TA marketplace, that we can work with counties and support all of you in the work that you are doing with ECM and community support. So hopefully we'll be live later this summer. The other big funding stream for ECM and community supports is what's called IPP funding, the incentive payment program. This is money the state gives to the managed care plan. The managed care plans often give out direct grants to providers to help jumpstart or increase efforts around implementation of ECM community supports. That initiative is going to dry up in June. And so if your managed care plan is offering these grants, encourage you or your partners to take advantage of it and apply for those dollars. They are going away very soon. Questions on this? All right, our next initiative is the JI initiative. And California is very proud that we are the first state in the nation that got approval from the federal government to start to offer Medi-Cal services 90 days pre-release in our state prisons, county jails, and our youth correctional facilities. It's very exciting, but a very challenging initiative. And we're starting to see pieces of this roll out. One of the things they started with was trying to figure out how to we ensure that everybody who's eligible is enrolled in Medi-Cal at time of release. So counties are working on this. Some counties are doing a great job. Others are still working on how to do this in a way that is meaningful for their population. So we have these puzzle pieces again, trying to say, how do we start to engage folks? How do we start to have some care coordination being done pre-release that will carry out into the community once folks have been released? So it's underway. You may have some county staff working on this. You may have community partners working on this, but we are starting to see some of this really get going in the state. Some of the pre-release services that are covered are case management services, looking at medications. So we want to have folks have that 30 days of medication upon release. So looking at how do we do that? How do we ensure that? We know one of the big issues with the JI population is we don't always know what the release date's going to be. Some folks are released at midnight or 4 a.m., so it can be very difficult to ensure they have what they need as they are released. What is good, I think, about this initiative, and hopefully it will play out in this way, but we are saying for folks, if they are still incarcerated, if they are eligible for these pre-release services, they should also be eligible for enhanced care management upon release. We're trying to tie these two programs together so folks can have care coordination happening both pre-release as well as after release once they're in the community. So again, just a real quick workflow, what we're trying to do here. The Medi-Cal application is a key component. Some counties have done a great job figuring this out. Some are still working on it, trying to make sure folks have Medi-Cal upon release. We're trying to do some screenings and care coordination planning prior to release that will carry over into the community once folks are released. A lot of these initiatives are going to be phased in over time. So the first date that all of these services can go live is going to be October 1st. I believe there maybe are just 3 or 4 counties who are aiming to do that on October 1st. And then counties can opt in throughout, I think it goes until December of 2025. So a long period where counties can opt in. Any questions on JI? Again, very brief overview, lots of exciting things happening. All right, next we'll go to our integrated care for dual eligible members, and dual eligible means folks who can be enrolled in both Medi-Cal and Medicare. So a lot of policy changes happening over the past few years around this, trying to align the plans that folks are enrolled in for Medicare and Medi-Cal. And we're trying to get these wraparound services for this population as well, do a lot of care coordination, all the same things we're seeing in the other CalAIM initiatives, break down silos, care coordination, serving that individual in a whole person approach. We also have a statewide managed long-term care initiative under CalAIM. Again, same principles here. We want to coordinate care, break down silos. Let's really serve that individual in a whole person approach. So how do we do that? We also want to make sure that we're doing this both in an institutional setting as well as a community-based setting. So looking at what that means, how do we ensure folks are in the most appropriate level of care? As you can imagine, there's also some thought given to what is most appropriate. Is it in the community? Is it an institution? What's going to save some dollars down the road too? So looking at all of those components in these initiatives. So again, didn't cover all 11 CalAIM initiatives. We did look at a lot of them at a high level overview. And again, as you start to think about what a county's role could be, what your county's role can be in some of these initiatives, it's going to be important to think through, are you a provider? Are you a supportive partner? What can a county do to ensure that these programs can have the best chance of success for the populations you're working with? Not all of it's in your control. A lot of it falls into the managed care plans as well, but looking at what can the counties do to really help make these successful. Any questions on, again, quick overview of CalAIM? All right, well, I'm going to encourage you all to take a quick break. Maybe we can do 10 minutes, come back at 2:25. And if you want to get some coffee, I encourage you all to do that. I know it's hard after lunch to sit through a long training, but we look forward to seeing you back here at 2:25.